Our next speaker is Dr. Stephen Wagaspan. He is a professor in the Department of Endocrine Neoplasia and Hormonal Disorders, Division of Internal Medicine, the University of Texas, MD Anderson Cancer Center in Houston, Texas. Dr. Wagaspan is a native of Louisiana. He graduated summa cum laude from Loyola University in New Orleans, where he also participated in Presidential Scholars Honor Program. He graduated with honors, including junior induction to the Alpha Omega Alpha Honor Medical Society from the University of Texas Medical School at Houston, which is now known as the John P. and Catherine G. McGovern Medical School. Dr. Wagaspan completed training in internal medicine and pediatrics, followed by a combined adult and pediatric endocrinology fellowship at the Indiana University Medical Center in Indianapolis. He maintains board certification in both subspecialties. Consistently recognized as one of America's top doctors for cancer in endocrinology. His major clinical and research interests are thyroid cancer, pituitary tumors, hereditary syndromes of endocrine neoplasia. Dr. Wagaspan has been in faculty since 2002. His favorite pastime is traveling. He has been to 6 continents, and it will not be a surprise if you have plans to go to Antarctica someday soon. Dr. Wagaspan, thank you very much.
Thank you, Susan, for that kind introduction. Over generous. And good to see everyone. It's so great to kind of feel like we're a little bit more normal by getting together. So it's so nice to be here and to see old friends and meet new ones. So our objectives today are for me to give you an overview of MEN1 and MEN2, specifically in pediatrics, review predictive genetic testing in this population, and then really focus, the management part will be focusing on how we screen these children for endocrine manifestations, not actually how we manage the endocrine manifestation. That would be a whole separate talk. So let's start with MEN1. So as we were all taught in med school, MEN1 is the 3 Ps, and that still holds true. It's primarily It's a disease characterized clinically by the presence of 2 or more of these pathognomonic findings, pituitary adenomas, and with the percentages here are what has been described as occurring in the pediatric population, at least in those with clinical manifestations. So we have pituitary adenomas, we have parathyroid hyperplasia, usually it's multiglandular disease, and then we have the pancreas, which is actually not just the pancreas, it's also the duodenum. It's duodenopancreatic neuroendocrine tumors. It's a mouthful. So it includes endocrine tumors in the pancreas, but also endocrine tumors in the duodenum, which are gastrinomas. Now here are the 3 definitions as proposed by Thacker in 2012, where we have the clinical, 2 or more of those manifestations, the familial, where you have a tumor like hyperparathyroidism and a first-degree relative with MEN1. And then there's a genetic diagnosis, which is when you just are found to have the MEN1 mutation without clinical manifestations. So it is this spectrum, and really in pediatrics, we're mostly on the left side of the spectrum. We're mostly dealing with genetic MEN1, at least in today's world. And there's been a good bit of research across the world. Whenever you see the countries, the map there, that's kind of where this research originates from. But we have to recognize, at least in 2022, most children will be diagnosed with MEN1 after predictive genetic testing. Okay, they're not going to be presenting clinically. Very few cases are now index cases, meaning that's going to be the first case ever presenting in that particular kindred. And this is older data, but still good data. Now, this was from 1998, so this really captures people presenting clinically. And you see here, at least in this population, about 52% had one. Most children, however, will actually be asymptomatic if they start to develop MEN1 disease during childhood. In most symptomatic children, so the children who actually get into problems will actually be greater than age 10. Important to recognize that mortality is not increased in pediatric patients with MEN1 because the risk of malignant neuroendocrine tumors is really, really low. And so what we worry about, at least in adults, is death from metastatic pancreatic or duodenal neuroendocrine tumors, as well as thymic neuroendocrine tumors. We fortunately don't see that in the pediatric population. And I can say that the youngest I've ever seen with metastasis was 17. So it's a very rare thing. So we have to remember when we talk about screening that it's not necessarily tied into reducing mortality in this population. It's focused on reducing morbidity in this population. I'm going to show you some penetrant slides for the sake of time. We're not going to go through this in great detail. Here's this UK study just showed you. It basically would make sense that you have, as a child, the younger the child is, the more likely they are to have just genetic MEN1, right? Not have any evidence of disease. Then they'll develop biochemical disease, such as a PTH of 10.4 with a PTH of 60. And then they'll become symptomatic later on in the process. So again, most of the symptomatic patients are going to be older. This is from the Dutch database here. And I've kind of put a little box at 20 and less, so you can see here the penetrance rates of hyperparathyroidism, pituitary tumors, and neuroendocrine tumors there. So you can see it's still quite low, and you start to see more of that uptick after age 10. This is from a large French database, and just again focusing on the pediatric population here. So you can see for hyperparathyroidism, the penetrance at age 20 is about 13%, 7% for pituitary, and 5% for neuroendocrine tumors. So let's focus on the most common manifestation, which is pediatric MEN1 related hyperparathyroidism. So if you look at all patients presenting with a clinical problem related to MEN1 less than age 21, hyperparathyroidism will be found in 75 to 95% of those children. So it's the most common. It's also the earliest clinical manifestation of MEN1. Again, most of these are going to be after age 10. The youngest age in the literature was age 4 with biochemical hyperpara. The youngest I'm aware of actually operated on is age 6. And I just actually reached out to those authors, and they actually don't have details to know whether this child was symptomatic or not. The oldest or the youngest with symptomatic disease was actually age 8. So very rare to get issues less than age 10. So again, the majority of children with hyperparathyroidism will be asymptomatic. And when we talk about symptoms, the primary presenting issue will be nephrolithiasis. Now, the issue is we don't have tons of long-term follow-up data. This is actually from Tasmania, this data here, that the issue with operating on children, right, is that you might do too much of an operation and cause hypoparathyroidism, or you will do too little of an operation and have persistent hyperparathyroidism requiring multiple surgeries in the future. So there's some more recent data that maybe looks a little bit better than this, but this was the big Tasman Kindred that was recently published. So the hard part is when you have a child with MEN1 so what happens when you're prospectively screening them, you're going to start to see these mild abnormalities. Okay, their calcium might be 10.2 and their PTH is 50. And just over time, that calcium just starts to creep up. And at one point, they become hypercalcemic with a non-suppressed PTH and are diagnosed. So when actually do we act? Understanding that surgery for MEN1 hyperparathyroidism is a 4-gland surgery. It's basically a subtotal parathyroidectomy where the surgeon removes the 3 most abnormal glands and leaves about a half of the most normal gland. So it's a pretty intense surgery in terms of risk. So of course, if a child has nephrolithiasis, if they're fracturing, if they have, significantly elevated calcium levels, those are clear indications for surgery. In adults, actually, it's interesting that hypercalcemia can drive gastrin production. And so I've seen adult patients who had metastatic gastrinoma and they got their hyperpara cured and their gastrin levels spontaneously decreased just with cure of the hypercalcemia. But we don't see that in children, but that could be a driver in an older patient. So the problem is there are no good guidelines for when surgery is actually indicated. To the left here are the MEN, the last iteration of the MEN1 guidelines, which really don't address when do you actually pull the trigger for a young patient with hyperparathyroidism. And then these are adult guidelines in general for just when do you operate on a patient with hyperparathyroidism. But children with MEN1 get caught in this black hole because it's really not addressed in either of these big guidelines. This is from the adult hyperpara guidelines, and just to show you some of the difficulties for us taking care of children. So one, they say anyone less than age 50 should have surgery. So by definition, that means any child who has hyperpara should have surgery, but we know we don't send everyone to surgery with MEN1 right away. And then, of course, they have the typical osteoporosis definitions, but this is not at all tailored for younger people. This audience obviously is learned and knows this well. This is more appropriate when I give this lecture to people who are not familiar with pediatric DEXA. But remember, the standard is total body less head, or subtotal BMD, as well as the lumbar spine. And we always use D scores, not T scores. And we have to remember that there are different definitions for osteoporosis in children. And so we tend to use low bone mass for age if the Z score is less than -2. And then you also need to think of the height of the child, right? And at least some, with a software change a few years ago, we were lucky enough to get this built in a little bit, where you can see here, this is, I'm showing bone mineral content, but this is for the age, the Z score is -3. But when it's corrected for the height Z score, the Z score for the bone density is up to -1. So that reassures you that this is actually a child with a normal bone density. So it's a fine balance. We want to minimize the number of surgeries that a child has during the course of their lifetime, and of course, we definitely want to avoid hypoparathyroidism because we all know how fun that is to take care of in clinical practice. And then we want to, at the same time, though, prevent that child from getting symptoms from hyperparathyroidism and also help promote their normal bone mineral accretion. So it is a balance. And this all also depends on having access to a high volume surgeon who is familiar with MEN1 and how to do these subtotal parathyroidectomies. So let's move down to the second most common manifestation of MEN1, pituitary tumors. So if you look at the percentage, it's 29 to 55% of patients diagnosed during childhood. Again, majority are asymptomatic. Prolactinomas are the most common of these tumors, occurring up to 83% in a recent study that was published. Again, you see this theme, right? Most age greater than 10. And about a third to a half are actually macroadenomas. This data is hard to interpret too, because remember, a lot of the older studies are capturing people presenting clinically, right? Not necessarily capturing people who have been screened for 10 years. So I think this number is going to go down because it's certainly not my experience in screening that you actually diagnose macroadenomas. That's quite rare. There is a female predilection for pituitary tumors. This is the youngest patient ever presenting with MEN1 and a pituitary tumor, a 5-year-old, who actually had an unusual case of a somatomammotroph tumor. My experience, and when we wrote a book chapter on this not too long ago, it's growth hormone secreting tumors are exceedingly rare in MEN1, actually. So I found this was quite unusual to have this combination. So most of the tumors will be prolactinomas, followed by functioning. This is one of the most impressive cases I've been involved in. A 13-year-old girl who presented with growth failure, vision loss. Unfortunately, she didn't need an endocrinologist for a while. She had been failing her growth for quite some time. And you can see here she had a giant chronoma, and she was actually, her father had MEN1. She and all her siblings had not yet been tested. So this was actually her clinical presentation of MEN1. But this is what I typically see in monitoring. This is a patient with MEN1 who's been monitored over the years here. And you can kind of see how these tumors develop on the left side of the pituitary at age 11. And over time, the prolactin's kind of up and down, and then more consistently becomes elevated. And at that same time, you can see this tumor clearly developing in the pituitary. Now, this is from the NIH. So they did publish their experience of children who actually had Cushing disease, or for Cushing's, and but I just say this, it's certainly possible, but less likely in, I think, our routine clinical practice. But something to think about. I mean, any child presenting with a pituitary tumor, I do screen for family history, and I do actually will occasionally routinely check calcium levels just to make sure they don't have MEN1. Okay, let's move down to the pancreas and duodenum. So actually, insulinomas are the most common functional neuroendocrine tumors that are seen in pediatrics. But we don't tend to see the other types of functional tumors like, VIPomas, somatostenomas, those sorts of things. The earliest age of diagnosis is age 5 with an insulinoma. And insulinomas in children represent the majority of NETs. So I'm sure you guys, like at Cook Children's and places that do a lot of hypoglycemia, will be more likely to see this type of presentation. But we're increasingly recognizing actually clinically non-functioning tumors. So these are tumors that are neuroendocrine tumors. They have the capacity to metastasize, but they don't present with hormonal hypersecretion. And it's now recognized that the youngest age was age 10 with a non-functioning tumor. As I mentioned before, malignant disease is extraordinarily rare, as are gastrinomas. So these fortunately only represent less than a quarter of these tumors. And if they are diagnosed, usually diagnosed in teenagers. This is the classic Zollinger-Ellison syndrome, where these patients get bleeding ulcers and dyspepsia, and diarrhea is a very common feature as well. But MEN1 is actually not just the 3 Ps. So for boards, that may be sufficient, but if you're really thinking of MEN1, you have to think of these other manifestations as well. So there are skin manifestations I always like to show, because if you're meeting someone with hyperparathyroidism and they have this on their nose, which is an angiofibroma, that they have MEN1. This is kind of this brownish kind of colored papule that occurs primarily just around the nose. And that is a very pathognomonic finding for MEN1. These patients can get these soft tissue tumors called collagenomas, that are just little localized collagen collections that look like that picture there. And then lipomas can be found as well. Females can get leiomyomas, but I have now seen my first adult male with a leiomyoma of the pelvis, actually, that I think is an MEN1 manifestation. But we tend to think of uterine fibroids as being related to MEN1. NETs can occur in the thymus as well as in the lungs. There are reports, these are older reports of brain tumors in MEN1. There's some recent literature that women with MEN1 might be at increased risk for breast carcinoma. And then finally, there is a link with adrenocortical tumors and very rare cases of pheochromocytoma. So what about adrenocortical tumors and MEN1? Well, fortunately, these are very rare. Only 0 to 4%, depending on the series, are diagnosed in children. The youngest was age 3 at diagnosis. And similar to any adrenocortical tumor, these tumors tend to present with virilization. So they'll have hirsutism, or here's a picture of an adolescent female with an enlarged larynx due to her high testosterone levels. And there have been some malignant tumors. So although rare, it'd be important in screening someone with MEN1, at least to make the parents aware to look for virilization. So those are the manifestations. A lot of our time in practice will actually be spent screening, right? Doing asymptomatic screening. And so I wanted to just spend a little time on that, and we're going to spend more time at the back end too, because it applies to MEN2 as well. So we assume that an earlier diagnosis and treatment will help to reduce morbidity and mortality, right? So in this case, we're not going to reduce mortality, but we're hoping to decrease the chance of the risk of morbidity. But we also have to recognize earlier identification of asymptomatic disease may actually lead to premature and unnecessary treatment that can also have a negative long-term impact on that child. So finding a 1 centimeter pancreatic neuroendocrine tumor in a 15-year-old, is that really helpful? Maybe not, right? Because you're not going to do anything with that. And what if someone actually, they met a provider who said, oh, you need to have surgery to remove that 1 centimeter neuroendocrine tumor? So that's kind of the balance we have to strike. And of course, years of episodic testing can have significant psychosocial and financial consequences for our patients and their families. This is kind of what's currently currently recommended. I kind of say here circa 2012 to 2017 because this is based on Packer data or a paper, and then there was a pediatric focused publication in Clinical Cancer Research in 2017. But this is going to be changing. I'm fortunate I'm part of the group now that we're looking at this again and hopefully trying to revise these recommendations and come up with some different thought process. So this is kind of what's on my mind now, and certainly give me feedback later because this will help me formulate the thought process in terms of formal recommendations. Of course, for adults with MEN1 who have children, they should be educated, right, about things to be aware of in children with MEN1. So, of course, teaching them symptoms of hypoglycemia, teaching them symptoms of possible nephrolithiasis, looking for any abnormalities in growth and development. It's not a lot. That's pretty much what you would look for to begin with. Genetic testing, we consider definitely by age 10. Again, some parents may prefer to know the genotype of their child earlier, and so I've been known to offer it to babies as well, just depending on if the parents understand what we're going to do with that information. I'm thinking now that biochemical testing, since I've shown you that most children less than age 10 actually don't have symptomatic disease or disease that's needing intervention, is that maybe we can be starting a little earlier than the currently recommended age of 5. Again, this could always be tweaked based on the child's personal history as well as parent preference. And in my own practice, I currently only start imaging around age 15, which imaging is MRI of the pituitary, of the chest, of the abdomen, the pancreas. Then, I usually wait till age 15. Again, if a child's already manifesting clinical issues, then you'd probably push that up. That child may be more likely to be severely impacted. So these are some thoughts that need to review the literature a little bit more and make sure the data is consistent. But this might be what the future looks like in terms of how we treat these children. A few more caveats. MRI is the preferred screening. I don't want to go through all of this. And Gary mentioned it in his talk about how any CTs does increase the risk of potentially a neoplastic process developing. And in this case, you have a child who has a hereditary predisposition to tumor development. And remember, for MEN1, you need that second somatic hit in order to develop the tumor. So, we try to avoid radiation, only use CTs really if it's a clinical question or a surgical planning issue. Some other issues to consider, it's, this child's relationship with the parents who often have parental guilt from having, passed on a gene mutation to their child, as well as siblings. It's like, oh, she gets all the attention, and the other kid without MEN1 may feel left out. There is anxiety, right, of every time a scan is about to have, you get really anxious. You just can't sleep until you get those results. So that's why I always make sure as a provider, I release results to patients as soon as I can, because I know they're sitting there worrying and waiting about this. And of course, getting MRIs in young children would require sedation, which is partly why I like to wait to age 15 or a little older so they can hold still and not have to be sedated for that. And since I do adults as well, I see this very frequently that, the child ages out of their parents' insurance, and then I look them. And they need to be seen, and they're there with no insurance, and I don't know who's taking care of them. And that's happened to so many of my patients once they get out of that pediatric bubble. So that's a real deal. And some patients can get tired of testing, and you can imagine a young adult, right? Well, I've been tested all these years; it's been fine. So why should I keep seeing the doctor now that I'm independent? And then everyone always has questions about future insurability. Remember that there are laws to protect at least medical insurability, but there are none to protect against life and disability. I only have 5 minutes? Thought I had till 12. Okay. We will make it quick then. Okay, let's switch to MEN2. So, MEN2 is related to germline mutations in the RET proto-oncogene, and MEN, there are different flavors of it, MEN2A and 2B. 2A is characterized by the 3 conditions you see here, and the percentages basically are dependent on the specific mutation that is inherited. There are 3 different variants of MEN2A as suggested in the MTC guidelines from the ATA. There's MEN2A plus CLA, cutaneous lichen amyloidosis, which is an interesting process. It's a very intense pruritus that occurs primarily on the at the interscapular back, and the patients scratch it, and over time they get secondary amyloid deposition in the skin there. So this is the mother of one of my children with MEN2A. The mom has on 10 mutations, actually can have full-fledged Hirschsprung disease, and that can be their initial presentation of MEN2A. And then finally, there are some kindreds where they don't have FEO or hyperpara, and those are known as familial MTC. But those are very rare families these days. MEN2B is the most severe manifestation of a germline ret mutation. Every child will get medullary thyroid carcinoma with MEN2B. They all have something on the phenotype that can be picked up, and there's a 50% chance of pheochromocytoma. Here's some of the classic phenotypic features. We tend to think of the oral mucosal neuromas. Bumps on the tongue are not normal, and many of these children may not even be picked up by dentists who see them. Of course, think of the arachnodactyly and crinoid body habitus. They have megacolon due to this kind of chronic intestinal pseudoobstruction and poor motility of their colon, but it can also extend to the esophagus. And I have some adult patients who actually have achalasia related to this as well. The two earliest manifestations of MEN2B, and we try to share this with pediatricians and family doctors. It's one, the early onset of constipation and problems, like colicky baby, particularly if they don't produce tears. So lacrima is a quite common finding in children with MEN2B. So, if you see MEN2B, ask the parents, do you remember if this child can make tears? And a lot of times they'll say, yeah, they've never shed a tear. This is just, you can look at this later and refer to this paper, but these are some, just re-looking at some of the other manifestations of MEN2B. So with a germline ret mutation, we know there's a natural progression from the normal C cell at the top left to a hyperplastic C cell, and then ultimately to a small or microscopic MTC, and then later by macroscopic, there's a risk for spread to the lymph nodes primarily, but also through the bloodstream to liver, lungs, and bone. The good news for us is that this process happens over years. It doesn't happen overnight. So it does afford this window for intervention right here where this process is starting. And so this is where we would consider an early thyroidectomy. I don't call it prophylactic thyroidectomies. Prophylactic means you remove a normal thyroid. So in this case, we want to remove a thyroid to develop medullary carcinoma. So that's why I call it should be an early thyroidectomy. There is a good genotype-phenotype relationship that we won't go through here. But let's focus on the timing of thyroidectomy for MEN2, because that's really one of the main questions we have to help address as the pediatric endocrinologist. So there is an evolution of this, again, for sake of time, both information about the genotype, the actual mutation, plus clinical data, primarily basal calcitonin levels to make these decisions. The mutations have been shuffled around and kind of assigned different risk levels. So these are the current guidelines in terms of timing of surgery. These are children with MEN2B, so thyroidectomy is recommended by age 1. Some people suggest even sooner. The higher risk mutations by age 5, and basically all the other mutations can be determined based upon the calcitonin as well as parent preference. So for these particular mutations, again, we'd still want to intervene here. And what I usually do is I suggest intervention right as the calcitonin is starting to become abnormal. And that seems to work well for most kids. To point out, the problem with MEN2B, we can make these recommendations, right, is the vast majority of kids with MEN2B have de novo disease, meaning they don't have a parent. So there's no opportunity to diagnose these children as babies. So, up to 90% will actually just be diagnosed clinically when their cancer has already spread. So surgery is usually therapeutic, not prophylactic. And if you look at this large series in MEN2B, even if you operate less than age 12 months, cure was only seen in 83%. But compared to 15% greater than 12 months. So it's still not a perfect recommendation. And again, there's a lot of risks operating on a 4-month-old, right, in terms of parathyroid function. There are a lot of ongoing issues. Again, for sake of time, I won't cover this, but happy to address it later. As we're still learning, exactly how the genotype predicts the disease course. There is an expanded landscape now that people are getting whole genome sequencing and things. We're finding more incidental threat findings, and how to interpret those, and how do we again predict the aggressiveness. I will just mention. So I will show the slide, so it'll go if you want to look at it later. But I just wanted to mention the screening for FEO. It's fairly easy in childhood because most of the children with a germline RET mutation will not be at risk for getting a FEO during childhood. And so the recommendations, at least based on the ATA, you get to pay to wait till age 11. Of course, there are some cases in the literature of age 8 and I think age 9 in MEN2B. But in general, you can wait till a little older age to start screening, which would just be plasma metanephrines. The other codons can wait till age 16. So hyperparathyroidism is very, very rare in childhood with MEN2A. So again, you can monitor that. It's kind of similar screening as to the pheochromocytoma, so similar ages. And unlike MEN1, the treatment for MEN2-related hyperparathyroidism is usually a single gland excision. This is usually single gland disease compared with multiglandular disease. All right, I'm going to wrap up with some general concepts because this is often what we see in clinic, right? Here's a 33-year-old man with MEN1 who has 4 children. And, the question is, well, do I test my children and when and how? So we've kind of already covered that. This, basically remind ourselves to test a child, right? We need to know the mutation that's in the family. So very important to get a copy of that test result, even if it's a distant relative. So actually have more information there. You know the mutation. It used to be we just do single site testing, but I understand now that next generation sequencing is just they're going to do it anyway. So, but it used to be if you had this mutation, you would only look for this mutation in the child. Some caveats I do like in someone like this where there's 4 siblings. I do like to start with the oldest and kind of scatter them so that there's no accidental sample switches, which could be devastating if you were to mislabel a child in that family. And then, you always would like to do the testing at the same lab that did the rest of the family, particularly if you're dealing with like a VUS or you're not sure. The lab can often order additional testing and offer free for family members to help you sort that out. So again, the thing to consider is at what age should genetic testing take place? For MEN1, I'm thinking maybe by age 9, MEN2, it's kind of depending on the age of when you would recommend thyroidectomy. But of course, parents may have different, they may want it done earlier. And then you have to ask yourself, what's the earliest known age of diagnosis of these manifestations? And even if the child manifests, are they going to really die from this or get into trouble? And then what will I do with the test results once I get the genotype? Again, in MEN1, I didn't mention this, but there are no genotype-phenotype correlations. So you can make a diagnosis earlier, but you're not going to do anything to really prevent something bad from happening. You're just going to try to pick it up earlier. And then in MEN2, there are good genotype-phenotype correlations. So in this case, knowing the genotype will lead to recommendations about an early thyroidectomy at the appropriate age for that patient. In the end, we want to always, respect the decisions of the family, particularly in MEN1, when it's less clear the benefits versus harms of testing versus not testing. And then just to point out here, remember our typical Gaussian distribution here. So we can apply this to screening as well. You can see here, look at from age 5 to 35. So the earlier you start screening, right, you're going to find more asymptomatic patients, and there's going to be an increasing risk of intervention. The later you start screening, you're going to have an increasing risk of disease, and they're more likely to be symptomatic. So, the age is the right age to start. Historically, it's been recommended, there's been a kid in the world with this at age 5, therefore you screen everyone at age 5 and less. But I think that's flawed logic. You have to look at the distribution of age presentation. And so I think if we think about it more logically, we're going to see that we can move up the screening a little bit. And the problem is there's always going to be exceptional N of 1 cases. Those are the case reports that make it out there. And, so I've taught myself to feel guilty if one child happened to get missed. It's just some children have an unusual course, but the vast majority of your patients, if we look at that plus or that 95% of the population are going to have a more predictable disease course. And again, with any, for all of the diseases we treat, even diabetes, right? We need to surround our children and their families with the multidisciplinary teams that can help to address all of these issues for them. So to conclude, currently MEN in most children, and this would apply to MEN2 as well, is diagnosed via genetic testing, predictive genetic testing. MEN1 is still defined primarily by the 3 Ps, but there are other clinical manifestations, particularly adrenal tumors, I want you to start being aware of. Usually actionable disease is in the 2nd decade of life, not necessarily the 1st decade of life. And timing of surgery for hyperparathyroidism is really not established in children. MEN2 is a disease primarily defined by MTC during childhood. There's good genotype-phenotype correlations, and there are guidelines for timing of early thyroidectomy that are out there. And then finally, we should keep in mind psychosocial and financial aspects as we care for these children with MEN1. So with that, I will end, hopefully, 1 minute early.
Thank you. For questions, I want to also remind you that if you have questions for any of our morning speakers, you can post your questions on the app in the session directly. You can also post in the community chat, the Q&A session, or you can email our speakers directly. So we have one question in the chat. Are you able to pull that up, Doctor? Yes.
So the question is, are there any manifestations of MEN1 and growth hormone deficiency? Not that I'm aware of, outside of if a child has had a pituitary tumor that's had surgery and maybe that's impacted. I mean, I know that we have treated patients with MEN1 and growth hormone who need it for growth, and that is not felt to necessarily increase their risk of developing other tumors. But I would think more strongly about, is this a child who really needs growth hormone? But it's rare to need that, but not directly related.
I just saw one. Are there other questions in the chat, Doctor? And I'll open it up to any questions in the room.
There's some other kind of tied ones. So isolated prolactinoma and no family history undergo genetic testing. So no, I mean there've been studies that have looked at that, and the yield is quite low actually if to genetically test all with pituitary tumors. So of course the family history is very important. So if there's any hint, that might be something 1 or 2 years, check the calcium level, and that's kind of how I screen for MEN1. In the FEO questions, a similar kind of thing, but or similar kind of question. No, MEN1 is not something we think about with pheochromocytoma in a child presenting. We would think of von Hippel-Lindau, or we think of the succinate dehydrogenase subunit B mutations. But the good news with FEO is there are FEO panels now that kind of include everything.